I'm going to talk today about bipolar disorder, and if some of you heard this last year, it will start with some of the same discussion items, information that I presented last year, but then I've woven in a number of new findings and new things that were interesting to me to tell you about. So you'll see that along the way. And anybody know who this portrait is? Virginia Woolf, who had bipolar disorder, and like many people with bipolar disorder, was very creative, and also, like people with bipolar disorder, had terrible depressions, and eventually put stones into the pockets of her clothing and walked into a river and drowned herself. So she kind of captures both some of the really positive attributes of bipolar disorder and the vulnerabilities to suffering and terrible outcomes. These are the topics that I'll cover. That it's more prevalent than most people are aware of, that with this disorder, much creativity and accomplishment can be part of it, but also depression is a big source of suffering in this disorder. I'll talk a little bit about some of the new findings in genetics and other areas, a little bit about the circadian and seasonal aspects of bipolar disorder, and then at the end about treatment. So bipolar disorder has been recognized for a long time. This quotation is from more than 2 centuries ago. And as you read through it, if anybody has a guess about who this might be, let me know. Who was a physician 2 centuries ago whose writings we still look at?
Freud.
Well, Freud wasn't quite 2 centuries ago. This is Hippocrates, sometimes called the father of medicine. And you go back and you read what Hippocrates had to say, and he was really a great observer and describer of illness. And he recognized that it's the biology of the brain that gives rise to all of human experience. And he made a classification of mental disorders that really is very much like the DSM today, and in some ways captures more than the DSM does. So for instance, we'll look at the DSM diagnosis of depression. In some ways, it's pretty narrow. And the DSM is trying to define some things so that when people talk about them, they're talking about the same thing. And when they research them, they're researching the same thing. But it leaves off the spectrum quality of, it's a category diagnostic system. It leads off the spectrum quality that's there with most psychiatric illness. So he talked about how there were toxic influences on the brain that could give rise to symptoms, but also postpartum psychoses, phobias, personality disorders, and so on. And this was a student of his whose description of mania I enjoy. So some patients with mania are cheerful. They laugh, play, dance day and night, and stroll through the market, sometimes with a garland on their head, as if they had won a game. This is euphoric mania, right? But others fly into a rage. The manifestations of mania are countless. Some manics who are intelligent and well-educated deal with astronomy, although they never studied it, with philosophy, but autodidactically. They consider poetry a gift of the muses. So there's the grandiosity, right? That they studied, they're expert in it, but they never studied it. And others fly into a rage. There's irritable mania. And this is Kreplin, who a little more than a century ago, I would say, began the DSM. So he was a German psychiatrist who worked in state hospitals and kept meticulous records of data about his patients over many years, and was eclipsed by Freud in psychoanalysis for many decades, But then, beginning about the 60s or 70s, his thinking and his writing came back into favor because he used an observational and descriptive approach, which really gained ascendancy over psychoanalysis in those years. And one of his main distinctions was between bipolar disorder and schizophrenia. And he noticed that bipolar disorder cycled and schizophrenia typically did not. And so he made the distinction between those two disorders, which has really been one of the foundations of the descriptive system that we use now. But like many things in life, it's becoming less clear as time goes on, and you'll see that later in this talk. So now with DSM-5, which comes out this month, after many years of arguing and disagreeing among the psychiatric community as to how to conceptualize the DSM-5, the overall movement in DSM-5 was to try, and I don't think it's successful at this point, but it was to try to move from just description to looking at what underlies disorders to capture them and describe them. So they wanted to use data from genetic studies, imaging studies, other kinds of analyses of the brain to characterize psychiatric disorder. And I think this is the desire of the field, but we're still not there in terms of having the data. But we're getting there, and you'll see some things this morning. So what is bipolar disorder? Well, in order to have bipolar disorder, you have to have mania. And what if you only have one manic episode over many, many years? Is that still bipolar disorder? Yes. That's still bipolar disorder. So you have to have a manic episode in order to have bipolar disorder. And this is bipolar 1 disorder, where you need to have abnormally, persistently elevated, expansive, or irritable mood for at least a week, or to end up hospitalized from your manic episode. And then here are the typical symptoms: inflated self-esteem, grandiosity, decreased need for sleep, more talkative than usual, or pressure to keep talking, insomnia or hypersomnia nearly every day, psychomotor agitation or retardation nearly every day, flight of ideas. You talk to somebody who's manic and they've skipped over 5 different topics, in the space of a few sentences, and you're trying to follow them. Distractibility, their attention is here, then on something else, then on something else. Increase in goal-directed activity, sometimes very productively, and sometimes in a very disorganized way. And excessive involvement in pleasurable activities. And then there's hypomania in the DSM, which is the same symptoms but less so. And not a week, but 4 days. And it raises the question, for instance, about what about somebody who gets hypomania for 2 days? Well, they're no longer a bipolar 2 diagnosis. They fall into the big, broad category of bipolar NOS. NOS means not otherwise specified. It doesn't fit the categories that are described.
Excuse me, is hypomania then the same as bipolar 2?
So hypomania is characteristic of bipolar 2, but people can have hypomania who don't meet the criteria for bipolar 2. So if somebody has a day or two at a time of hypomania, they don't meet the criteria for bipolar 2 and they fall into bipolar NOS. But in fact, people talk about brief hypomania like that as bipolar 2. That's kind of a commonly understood reference that somebody gets hypomania and also depression, and that's more characteristic of bipolar 2. But if you're being rigorous, you have to have 4 days of hypomania to have bipolar 2. So these are the diagnoses that are in the DSM. Bipolar 1 and 2, as we talked about, then NOS. Cyclothymic disorder is mild mania and depression that cycles. And then mood disorder, not otherwise specified, if it doesn't really even fall into the bipolar disorder, not otherwise specified. Now, if you look in other diagnostic systems like the ICD-9, you can find other categories of bipolar disorder. For instance, hyperthymic personality. What's that? It's somebody who's always a little manic. So they don't cycle, they just stay at a level of some degree of mania all the time.
What's that called?
Well, it's called hyperthymic personality. And I think in the ICD-9, their language is persistent hypomania personality. So they actually classify it under the personality disorders. So it shows you how confused the diagnostic system is, because if this is in the bipolar spectrum, it should be in the bipolar disorders. But because it's a steady style of relating, ICD-9 puts it in the personality disorders. And then rapid cycling bipolar disorder isn't really mentioned in the DSM, but in fact, there are quite a few people whose cycles of bipolar disorder, mania, and depression are rapid. And they don't get captured in the DSM. They fall into that NOS category. So, here's one indication that bipolar disorder is widely prevalent. So, under the DSM, what's the rate of bipolar 1 disorder? Approximately. It's about 1 out of 100, roughly. And so bipolar 1, which was for many years, back when I was in residency, now 25 years ago, that was bipolar disorder, bipolar 1. And there really wasn't much recognition of these spectrum disorders that I'm describing today. And it was not so frequent. It's about 1%. But now there's this concept of bipolar spectrum, and you can see here bipolar 1's out at the right-hand end, but then once you get beyond bipolar 2 and NOS, at the left-hand end of that, it says unipolar depression. And Kreplin argued that there were unipolar depressions that were part of the bipolar spectrum because they cycled. They were mood disorders that cycled. They just didn't cycle into mania. So what would support the idea of a bipolar spectrum disorder? Well, if there were genes in common, if there were family histories where relatives of people with milder bipolar disorders had relatives still having bipolar disorder, if we had imaging studies that supported this, if we had treatment response that supported it. And in fact, we do. And this is, I think, one of the most interesting slides. It takes a minute to absorb. But the bottom axis is severity. So way out at the right-hand end is bipolar 1 and then schizoaffective disorder. So that's bipolar with psychotic symptoms. And the other axis is percent of individuals with this. So you can see it's a very small percentage of people who have bipolar disorder with psychosis, less than 1%. Then you go up to bipolar 1, and it captures another 0.5 to 1% of the population. Now you start to go up to bipolar 2 with the 4 days of hypomania, plus bipolar 1 and schizoaffective disorder. Well, now you're up at about 2, maybe 2.5%. And if you keep going up the curve and you add in bipolar 2 that's shorter than 4 days, you're up to 5%. And then with cyclothymic temperament, people who are hypomanic much of the time, or at least sometimes, now you're moving up toward 6, 7, 8%. So this is part of the challenge in the field right now, is to understand clearly this spectrum and to find evidence that these things are connected and are part of the same thing. And this is a trend over time since 1994 that shows in adults the top line, in children the bottom line, the increase in the rate of diagnosis of bipolar disorder. And it captures some of the controversy, because if you look at the child diagnosis, now it starts with a very small number, but it's increased 40-fold over about 10 years and more since then. And it's created all this controversy because now children are being prescribed atypical antipsychotics like Seroquel, much more than they used to be. And is this really bipolar disorder, or is it something else? And these typically are children who are irritable, oppositional, are very moody. And I think the data is beginning to show that a certain small percentage of those children, particularly those who cycle, probably go on to have bipolar disorder, but most don't. It's something else. And that's where, the genetics, the imaging, the family histories, the studies over time, the naturalistic studies that follow people, will help to clarify this. I think overall, the weight of evidence is that bipolar disorder has been overdiagnosed in children, although it probably started out being underdiagnosed. And I think the pendulum is beginning to swing back to try to more accurately capture that. And this slide I include because Darcy liked it so much last year. And it's just an interesting slide. So is bipolar disorder occur at the same rate across the world? Well, there are conflicting studies, but overall it does tend to occur at the same rates, but there is significant variation. This slide is about seafood consumption, omega-3 fatty acid intake by country, and the rate of bipolar disorder. Now, at the very high end is Germany, that has a very high rate of bipolar disorder in the population and a very low rate of seafood consumption. And way out at the end is Iceland, where apparently they have almost no bipolar disorder. And we're not talking about seasonal affective disorder today, but that's a good point. And I think the jury is still out on omega-3 fatty acids. There's a lot of interest in their use in mood disorders. It isn't yet entirely clear how helpful they are, but there's a lot of interest in this. So creativity and accomplishment. Those, just a few souvenirs from my bipolar days, which is true. So Kay Redfield Jamison has written about this, artists, creativity, mood disorders. The United States, I think in many ways, the hypothesis that I've seen is that people who are adventure-seeking, novelty-seeking, seeking fame and fortune come to the United States, and then I add, when they get there, they come to the West Coast. And maybe the gene pool selects for bipolar disorder because those characteristics of entrepreneurs and so on are characteristics of bipolar disorder. So there's a cultural value of mania. Now this is one person David Brooks wrote about in the New York Times who sounds manic. And I'll just read one paragraph to you. This is Elon Musk, who decided that what would most transform humanity would be the internet, sustainable energy, and space exploration. So he created PayPal, Then he invested in SpaceX, a space exploration company, Tesla, an electric car company, Solar City, a solar power company, and Everdream, a data software firm. And he's working on Hyperloop, which I would be very curious to know what this concept is, to get people from Los Angeles to San Francisco in 30 minutes. And also he would like to start a space colony on Mars within 10 or 15 years. So this is somebody who dreams big, but has also had big accomplishments. And then this is a fellow psychologist who wrote a book called The Hypomanic Edge. He wanted to study entrepreneurs, and he had a hypothesis that they were hypomanic. So he placed an ad in the newspaper and said, are you like these things? And energy, ideas, driven, grand ambitions, little sleep. Sounds like hypomania, right? And then some others as well. And he got a lot of responses to this ad. And he had people who called him up and wanted immediately to meet with him. And he was asking people to rate their degree of these characteristics on a scale, 0 to 5. And people would insist, no, I'm a 6, I'm a 7. You have to write that down. The only characteristic that they didn't endorse was prone to making enemies and feeling persecuted. They didn't like that one. But everything else they acknowledged. And here's another person. This is Dr. Flaherty. She's at Mass General at Harvard. And she had a postpartum depression and then a manic episode. This was around age 30. And she began to write poems, autobiographical work that was published. She published a book called The Midnight Disease about writer's block. And she has channeled her hypomania into many projects, both in medicine and out of medicine. She now studies the neuroanatomy of empathy. This is another very interesting area, by the way. Mirror neurons in the insula cingulate inferior frontal lobe. Mirror neurons are what gets stimulated when we see somebody else experiencing something, feeling something, and it evokes something similar in ourselves. It mirrors that state. And there's a great deal of interest now in this. And this was a very interesting statement to me. She said, what made me empathic were my depressions. So, and this is what Kay Redfield Jamison said as well, that creativity was also had a source in depression as well as in mania. And she writes during her manias, then she edits during her depressions. Right? Because when you're manic or hypomanic, your judgment is often not so good. You know, everything's exciting and terrific. And then here's one other example. Looking at, this is a random sample, 152 majors in art school, comparing them to 152 majors in professions such as accounting. And when they scored the personality profile, the art school students scored much higher on cyclothymia scales. And the writers, the investigators wrote, the features of hypomania predispose people to creativity, and depression might provide fresh insights which can be executed during cyclothymia. So maybe this back and forth is a part of the creative process. Now here's another side of the coin is depression is much more common in bipolar disorder. So what's the average length of time before somebody is diagnosed with bipolar disorder? What would you guess? It's about 10 or 12 years. And why would it be so hard to diagnose somebody with bipolar disorder if they're having mood symptoms? Why does it take 10 or 12 years?
They come to the doctor when they're depressed, when they're hypomanic
Right.
or manic, they're fun to be around.
Right. Well,
for adoption.
that
Unless they're manic.
right. If they're hypomanic, they're not going to come in asking for help, right? So they're going to stay away. Unless, as you say, they get so manic that the police are involved, the family's upset, and so on. Another reason is that in bipolar disorder, depression comes first almost always. And many people have years of depression before they ever have a manic episode. Sometimes the way that you realize that the diagnosis is bipolar disorder is that you treat somebody's depression with an antidepressant medicine, and what happens? They get manic. So you have to rethink things at that point. So this pie chart is from a study done at the NIMH following a large number of bipolar individuals who kept, I believe, weekly journals of their mood states. And it essentially was a naturalistic study of what are the mood states that people experience. And you can see there's much more depression than mania. And the least common state is mixed, mania and depression, which also does happen. I think what's a little misleading about this pie chart is that in that 52% of no symptoms, in fact, people have subsyndromal symptoms much of the time. So that means that they have some depression, but it doesn't meet what the DSM says are the criteria for depression. Remember, DSM is that category, and you have to get above the bar in terms of meeting the symptoms, but it's a spectrum. And you can have a little bit of depression and not by DSM be depressed. And in fact, most of the time people are having some degree of mood symptoms. The toll of depression can be very severe. One of the clues that somebody's mood disorder is a bipolar disorder is if their depression is very severe. Very early onset, very severe depressions, much higher likelihood it's a bipolar disorder. People describe leaden paralysis, feeling like they physically can't move their limbs. And the rate of suicide in bipolar disorder is substantial. I don't have it right at hand, but I think it's on the order of 15% of people with bipolar 1. So this is that NIMH study, 146 patients. They were bipolar 1 patients. They kept a journal weekly for almost 13 years. And in the text, it does talk about subsyndromal depression and mania. These patients changed symptom status an average of 6 times a year, and polarity, meaning they go from depression to mania or otherwise, or mania to depression, 3 times a year. And that leads to one of the current real controversies with bipolar disorder, which is, do you use antidepressants to treat people with bipolar disorder? And there are researchers who've done good work that shows if you use antidepressants, you have a very significant chance of creating mood instability and cycling, pushing people into mania, getting them cycling between mania and depression. And they argue that you shouldn't ever use antidepressants in bipolar disorder.
That happened to me.
That happened to you.
It was very serious.
And there's another group of researchers who say, no, there are many patients who can be treated with antidepressant medications when it's appropriate. You should always have somebody taking a mood stabilizing medicine. You don't ever use an antidepressant alone, but you can add an antidepressant when it's needed. And I, for instance, had to review with a Blue Cross physician who criticized me for adding an antidepressant to a bipolar patient's treatment because he said this is now contraindicated. So it made me curious, and I went to an educational dinner with Michael Gitlin, who's the head of the mood disorders program at UCLA. And there were about 15 psychiatrists there. And I asked him, what do you do when you have a bipolar patient who gets depressed? Do you use antidepressants? Do you not use antidepressants? And he said, let me ask the room. And he asked all 15 of us, do you use antidepressants? Every single psychiatrist uses antidepressants. And his comment was, in the real world, with people who are suffering with depression, he couldn't imagine not using an antidepressant if he couldn't get somebody well with mood stabilizing medicine. Now, it does get complicated. There are mood stabilizers that are antidepressant. That can be a first good choice if needed. But this is another area where we don't really understand well enough the data. So a little bit about the neurophysiology of bipolar disorder. And these things were really, these are relatively new findings, and they're very interesting. So this is a look at 500,000 SNPs of genes, little snippets of genes, comparing bipolar disorder individuals with people who don't have bipolar disorder. And over all the chromosomes and all these sites, there were 2 that got above the dotted line, meaning that they were associated with individuals who had bipolar disorder at a rate that was significant compared to healthy controls, people who didn't have the disorder. And then 1 other gene that almost got to that level of significance. And people have been searching for the bipolar gene for decades. There's no bipolar gene. It's polygenetic, and it's probably very complicated how it works. But these are some interesting findings. So these were 500,000 sites. The 2 genes that were different, one affected proteins in the cell membrane. So cells have lipid membranes, fatty tissue membranes, and things have to get in and out of the cells. And the channels that things get in and out of the cells are surrounded by proteins. And in bipolar disorder, the findings are suggesting there's something about the way charged atoms move in and out of the cells that's different in bipolar disorder. The second gene was about an effect on the calcium ion channel, one of those channels. There were no common genes that had a very big effect, but the ion channels, the nerve signaling, seemed to play an important role. And this will get us back to Kraepelin in a minute. So he made the distinction between schizophrenia and bipolar disorder. And toward the end of his career, I wish I could find the quote. I couldn't find it for this talk. He said, "I'm dismayed to acknowledge that the more years I have done this work, the less confident I am about the distinction between manic depressive illness, which is what he called it, and dementia praecox, which is what he called schizophrenia." So he got less certain about what was really one of his most important findings across his life. So this was a study in Sweden where they have health registries, and they're able to study illnesses in populations much better than we can. Maybe one day we'll have a single-payer system and a common platform for gathering data and be able to do this. They looked at 9 million individuals, and they looked at 40,000 people with bipolar disorder, 36,000 with schizophrenia. They asked a couple of questions. One, if you have bipolar disorder, do your relatives have that at a high rate? The other question they asked was, if you have bipolar disorder, do your relatives have a high rate of schizophrenia? Now, you would think there would be a high rate of bipolar disorder, right? But it turns out there's also a high rate of schizophrenia among relatives of individuals with bipolar disorder. And in the other direction, it's true too. When they looked at individuals with schizophrenia, their relatives had a high rate compared to the population as a whole of schizophrenia, but also bipolar disorder. So these things now are kind of merging more than they used to. And the comment at the end of the article was, clearly our diagnostic nomenclature must change eventually. Now, to make it even more complicated, this is the era of big data, right? You've heard of big data? So now, computers, companies capture enormous amounts of data about every transaction. Every time you buy something in a store, it goes into a computer and there's a profile about you. Actually, you know, now when I use my internet browser, Google tracks what I'm doing on the internet and puts ads there about things that I've looked at recently, which I find creepy. And I don't like it. But it's big data. I mean, Google is collecting enormous amounts of data about what everybody searches about. So this was kind of a big data project. They gathered genetic data, 19 countries, 33,000 individuals with psychiatric illness, and they looked at variations in several million places among 3 billion DNA nucleotides. So we've got this ability to bring information science and biology together more and more. 4 DNA regions correlated with a small risk of psychiatric illness. 2 of them involved calcium ion channels. But here's the really surprising thing. All of these illnesses, bipolar, schizophrenia, major depression, autism, attention deficit, all share these same DNA region differences. So we're trying to make distinctions between illnesses by observing them and describing them accurately. Now the biological data is saying there's a lot that's in common among all these illnesses. But the fact that these 5 psychiatric illnesses all have the same genetic variation, what's going on? You know, what is, there must be some common underlying templates that create a vulnerability to this illness, and then there must be other factors looking at how it gets expressed. And it's long been known that if you have bipolar disorder, your likelihood of having attention deficit disorder is much higher. It's in the range of 20% or more likelihood that you'll have ADHD. I'll add 2 other wrinkles to this discussion that will make your head spin a little bit more. Epigenetics. So epigenetics are environmental influences that affect gene expression. So if you have childhood trauma, it turns out that you methylate certain portions of the gene so they don't get expressed. So we used to think genetics was destiny, right? But genetics interacts with environment and it expresses some genes more, other genes less. And here's another, this just makes my head spin. These changes that happen epigenetically can be passed on to the next generation. But we won't even get into that yet. There's methylation that binds genes and lowers their activity, histones that increase gene activity. And here's one example. Methylation of the 5-HTT promoter region in people who have childhood abuse. This promoter region is methylated and it's linked to an increased rate of antisocial personality disorder. There's another study that looks at the dopamine transporter gene and methylation in eating disorders. So certain life experiences then can predispose you to psychiatric illness. And then here's another one. This is very hypothetical. There was a study about retroviruses, which are viruses that get incorporated. They go into your DNA and they stick in there. And there's this particular retrovirus that was associated with multiple sclerosis. And they said, well, I wonder if it's associated with bipolar disorder and schizophrenia. And it turns out that the level of expression of this little gene fragment from a virus that's in our DNA is expressed much higher in bipolar disorder and schizophrenia. So this story is very complicated. There's not a bipolar gene. There's a bipolar vulnerability that's polygenetic and affected probably by many circumstances. There are structural changes in the brain of people with bipolar disorder, and I'll go through this quickly. But essentially, shrinking of gray matter, changes in the size of the amygdala, which is an emotional center in the brain, increased ventricular size, which is the spaces in the brain that cerebrospinal fluid flows through. So those get bigger if the brain itself, brain tissue itself is shrinking. And then the more episodes you have, the more brain effects. So those three scatter charts are healthy subjects, first episode bipolar, and multiple episode bipolar. And you can see the change in the right-hand measure of ventricular size. I'll skip this a little bit. Lithium turns out to be a more and more remarkable medicine. It's a little bit like aspirin to me. Aspirin's a really remarkable medicine. Lithium promotes brain tissue growth. It resets the circadian clock, the 24-hour clock. And I'm going to move on to something else. So one other topic area, rhythms and seasons. This graph is the rate of admissions of patients with mania to a psychiatric hospital. This one's in Brazil. But summer months, spring, summer, the rate of mania goes way up. The rate of admissions to the hospital goes way up. Fall, winter, it drops very much. So we know at 5 East that by April, May, we're going to begin to see more mania. Now, why would that be, right? It has something to do with light. This is an observation by somebody speculating that maybe bipolar disorder developed as an adaptive trait in the northern climates, which had extreme winters during the Ice Age. So people had to get hypomanic for the spring and summer to get a lot done. Who knows? It's an evolutionary psychiatry. But we have a center in our brain called the suprachiasmatic nucleus, SCN, that's our 24-hour clock. It's only 20,000 neurons. It's very small, but it's set by light. It has a 24-hour clock that's autonomous. It runs on a 24-hour cycle itself, but it's reset by light. And it is part of, along with melatonin, what gets us to sleep. And there are sleep disturbances in mood disorders that are another interesting topic, but that's for another day. And in sleep and bipolar disorder. So if you sleep deprive somebody with bipolar disorder, there's a good chance they'll get manic. If somebody with bipolar disorder is depressed and you deprive them of sleep for a night, their depression gets better right away at a very high rate. The unfortunate thing is it doesn't last more than a day or two. And light therapy for depression, where you look at very bright light, sunlight strength, early in the morning consistently, is a very robust treatment for depression. So these light cycles and these 24-hour cycles are very involved with mood disorders. A couple of other interesting findings, then I'll stop. ADHD. It turns out that if you look geographically at areas of high-intensity sun, ADHD rates are substantially lower. And the hypothesis is light resets the circadian rhythm, and that's involved in attention deficit disorder. And then seasons in psychiatric illness. And this is big data again. They looked at Google searches for mental health topics. And here, this was Australia and the US. A few of these findings. Eating disorder searches were 37% lower in summer. Schizophrenia, 37% decreased in summer. Bipolar disorder, 16% less in summer. ADHD. So just as there's a common genetic underpinning, does light and the circadian rhythm influence all of these disorders? And I'll say a few more words and then I'll stop for a few questions. So we have improving treatments for bipolar disorder. Not good enough, but substantially better decade by decade. And new findings coming all the time. So you remember those calcium ion channels? It turns out calcium channel blockers, which are hypertension medicines, are effective in bipolar disorder, and they regulate calcium ion channels. So there's a lot of interest in that area. And there are a number of other new initiatives in terms of medications that can really make a difference. And psychosocial and psychotherapy approaches make a big difference for bipolar disorder. If you get regular sleep, it has an enormous impact on stabilizing your mood. And there's an approach called social rhythm therapy that looks at a range of social rhythms and how people can improve their ability to have regular social rhythms and get more stable in their bipolar disorder.